Thank you so much for being here. My name is Kim Porter. I'm the Executive Director of Be a Part of the Conversation. Also with me is Bob Lamb, who is our Director of Operations and Program. We have two presenters. But first, I want to thank our hosts for tonight's program. Bucks County Drug and Alcohol Commission is a partner of ours, and we're very grateful to them for supporting our organization and all the information that we're providing tonight and on our website and lots of other resources that I'll tell you about in a moment. I want to let you know that we are going to allow time for Q&A after you hear from our two presenters. We are recording this program, but I want to assure you that your image that we're seeing on Zoom, your name will not be visible on the recording. If you ask a question later on, I will edit out anybody's image, their question, that sort of thing. We may keep in some of the responses if they're helpful to a general audience. But you will not see yourself on the recording, only the presenters that are here this evening. At the end of the program, by the way, you can ask questions in the chat as they come up, as the presenters are speaking. Anything that you would like to remember to have us ask, go ahead and drop that in the chat at any time. We'll open it up, though, after they're finished speaking for all of your questions. There will be a survey that comes up at the end of the program, and we really appreciate you taking a moment to give us your feedback about this program so that we can be informed about what you're looking for in the future, other topics. Speaking of other topics, we have a lot of programs coming up over the next several months. You can find a lot of them on our calendar. That's at conversation.zone/calendar, and we'll get all these links to you in the chat. We also have a lot of information, a lot of recorded programs on our YouTube channel, and I hope you'll visit that as well. And want to make sure that you're aware of a couple of services that we offer in addition to these community events. We have parent partnership meetings. Oh, by the way, please mute yourself unless you're ready to ask a question. So we have parent partnership meetings that take place throughout the region, whether in person or virtually. We have 21 meeting every week, 52 weeks of the year. About half of those are in person and about half are still being conducted on Zoom. And you can go on that page on our website for parent partnership and see all these purple buttons are in-person meetings. All the green buttons are Zoom meetings. You can click on any one of these to get details about that specific meeting. It'll have either a link to join via Zoom. You don't have to register, totally free to attend. If it's in person in purple, then you click on that to get the address or contact information, any of that kind of info that you need. These are similar to Al-Anon or Nar-Anon meetings, but they're not 12-step. We have crosstalk, and we're all parents or guardians or grandparents, but we're in that parental role. Very, very helpful. We also have a family recovery course. Very, 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 very excited about. This has been this is our second full year that we've been presenting this course. It's a 3-part course, totally free to attend as well. It covers basically what happened to my loved one, what happened to my family, how do I recover as a family member. It's capped at 12 participants. It's co-instructed by 2 family recovery course instructors who are peers. So people like me, I have a child in recovery. That's what brought me into this work and this world. And so we have had a lot of experience. We've been educated about this, and we're passing along some, I think, very helpful information to our participants. So I hope you'll visit that section of our website if you haven't taken the course and you think it might be helpful. So tonight we have 2 speakers, as I mentioned, Dr. Sean Fogler, and we have Katherine, or Kay, who is a family member. I'm going to start by introducing Dr. Fogler, who'll be with us first. He is a physician living in long-term recovery. He's the co-founder and consultant with Elevist, a public health consulting group, and he's the co-chair of the Health Justice for Pennsylvania Coalition, which is a collaborative initiative with Elevist and the ACLU of Pennsylvania. Sean works extensively with healthcare systems, criminal legal system stakeholders, and community-based organizations as a public health, drug policy, and stigma expert. He uses his lived experience to educate and inform, reduce stigma, and improve public health policy for mental health and substance use disorders. So I'll turn it over to you now, Dr. Fogler.
Thanks so much, Kim and Bob, for having me. Tonight, we're going to talk a bit about drug use and recovery stigma. As Kim said, I'm a physician living in long-term recovery. I practiced anesthesiology in the Philadelphia area for over a decade. I myself had a substance use disorder, got into recovery in about 2015, and also was impacted by the criminal justice system. So I've kind of seen and experienced a lot of the things I'm going to talk about. It's what drives a lot of my work today. The personal and professional stigma that I experienced kind of traversing these issues led me to do some research over the past few years on stigma, and I continue to do that work today. Um, and so, needless to say, I'm quite passionate about these issues, and they're really important to me. And in terms of what's going on in our culture and society today, I think it's critical to address these issues. So I pulled this quote actually um, from a Human Rights Commission report. This is a recent report, and laws, policies, and practices deployed to address drug use must not end up exacerbating human suffering. And this is a simple statement, but I think it's a really powerful statement because um, a lot of the policies and practices and the things we're using to address drug use, addiction, and overdose today are causing significant harm. And you'll hear people talk about addressing social determinants of health, but one of the things we really need to deal with and address are the political determinants of health. And the criminal legal system, is a big part of that. Um, and so I'd like everybody to kind of keep that in their mind, as we're addressing. And a lot of these policies and practices are well intentioned. It's interesting because I've done a lot of work with law enforcement and a lot of work with healthcare systems. And the reality is the vast majority of us, almost all of us, want the same thing. We don't want people to die. We don't want people to suffer. We want people to get into treatment and recover and be connected to their families and communities. And but we approach it from so many different angles, and law enforcement have their kind of perspective and the challenges, and the healthcare systems have theirs. And so we have to find common ground, and we have to have these conversations to really move things forward. Let me move forward here. Sorry for the moving slides. Okay. So yes, this is the inside of an airplane. And just to highlight, we lose over 300 people every day to drug-related overdose deaths. Every single day. That's every single month. There were 3 9/11s that happened. Now, this is drug-related. If we add alcohol-related deaths, and we don't talk about alcohol because it's a legal drug, we can double that, more than double that. And I think that gives us kind of a good view of the significance of this problem. This is a massive public health crisis, and it's a wake up call. And a lot of what we're doing is not working. And so this is from the National Survey on Drug User Health. This is the most recent one, and this problem affects a large percentage of our population across every demographic, every age group. It's not those people, and frequently we see, somebody in Kensington or under the bridge, and we point our fingers and we judge and we shame them and we think it's those people. But the reality is, I'm a physician, I have a substance use disorder. Our most recent survey, we surveyed 6,000 healthcare professionals, and 30% of them identified as either using drugs or having an addiction. If you add the number that are in recovery, that number goes to 40%. Those are healthcare professionals. We know in attorneys, high rates of alcohol use disorder, right? This problem affects all of us. It's not those people. It's not that family or this family. It really is all of us. And there's a lot of shame, when it comes to this disease. and people are afraid to open up, understandably, because of the judgment and the discrimination. Not just the individual that struggles with the disorder, but the family, right? But the reality is we're not really alone. We think we are, but we're not. And so, we have these challenges: overdose, addiction, mental health issues, identity-based disparities, things like gender issues and poverty, race, right? And it's my belief, and the research really supports this, that this thing, stigma, which seems like a nebulous thing, but really it's discrimination, right? Overshadows all of this and holds us back and makes recovery very, very difficult. So I think it's something we have to talk about and we have to address if we're going to move forward. And I just wanted to mention this because this is something I've been thinking a lot about lately. And the Surgeon General, Vivek Murthy, just released this on our epidemic of loneliness and isolation. And I think this is a big part of what's driving mental health and overdose crisis today. And I don't think we talk about it enough. But I think many individuals who struggle with alcohol or substance use related issues, and I know this was the case for me, felt very isolated and disconnected, even though on the surface, you kind of put on the mask and you play the part and you feel connected to the community and the people around you. But there is this like deep seated, and COVID obviously exacerbated this in a huge way. There is like this deep seated feeling of loneliness and isolation, and I see it in our children. I have a young daughter, um, and I know she feels that too. And I think this is a big part of the problem. And I think conversations like this and these connections are so powerful, in terms of getting us out of this kind of feeling that drives and this our epidemic of loneliness and isolation drives substance use. It drives addiction. It drives overdose. Right? People die alone, isolated, and disconnected. And I think we have to address this if we're going to move forward. And a lot of our strategies, if you think about the criminal legal system, and how we punish, right, and shame people with this disease, drive a lot of this too, right? And so it's something important to consider. And I just this was in an NPR article, and I hate to be so dark because there is hope, and we will get to that, and positive things. But just this, the life expectancy in this country relative to other developed countries is in free fall. Is in free fall relative to other countries, and I think a lot of the mental health issues and substance related issues are contributing to this in a very massive way, and it should be a wake up call. So we're going to talk a bit about stigma. And so what is stigma? And this is a classic definition, but it's an attribute, behavior, condition that's deeply discrediting, right? It can be a disability, it can be the color of your skin, the fact that maybe you don't have a home, can be an addiction, substance related issue. And in terms of socially and in society, it's a mark of disgrace, right? And a mark of shame. Because we know how our friends, family, colleagues, how they talk, right, about this disease. We hear it. And I remember hearing it, in the hospital. Even when I was struggling, I would see it, hear it, and I contribute to, I was also, guilty of making those comments. And it was almost a way to like distance yourself from quote unquote those people, even if you are that person, right? It's almost a defense mechanism, right? If I judge and shame, I know that the people around me, won't judge and shame me, right? I'm part of the part of the tribe. And I think the other thing about stigma that is very rarely talked about is that it's a language of relationships. And what I mean by that is somebody with these stigmatized identities, right? Like a substance use issue, or somebody who's using drugs, or gender issues, or whatever issue it is, everywhere they go, they're on guard, right? When am I going to be judged? When am I going to be shamed? When am I going to be discounted? Like you think about somebody who's using drugs or has a substance use disorder, and they show up at their healthcare, at their physician or the nurse they're seeing, and they're just waiting for it, right? They know they're going to be judged and shamed, and shame is, and I'm sure many of you know this and have experienced this in some way, shape, or form in your lives. Like that shame is really toxic and really powerful. And the thing about shame is that, you know, physical and emotional pain are experienced in similar areas of the brain. So when you're shamed or you're judged or you're discounted, it feels physically like you're getting cut with a knife. It's extraordinarily painful. And it causes people to isolate, it causes people to not ask for help. Um, and it generates a lot of fear, and uncertainty. And the best thing to do is to hide, right, and avoid. And that's what we don't want. That we want people to be open and ask for help and talk to us, families or their colleagues or people in the community. And this thing, stigma, this discrimination, um, really keeps people at bay and keeps them on the margins, right? And we know that's where people die, right? Alone, isolated, and disconnected. There's actually many different types. These are the most common. Public stigma is, our societal perceptions, how we judge, others. Structural is when those ideas and beliefs and perceptions, those negative ideas, beliefs, and perceptions about drug use or addiction are baked into our policies and practices. And you'll see that in health systems or the criminal legal system, in most correctional settings in the state of Pennsylvania. You can't get medications for opioid use disorder. In fact, you used to not be able to get them at all. Now that's starting to change for a lot of different reasons, but those were baked in, right? If you came in and you had an opioid use disorder, too bad, right? You didn't get treated. Self-stigma, I always think that that's one of the most dangerous. That's when we take all these ideas and perceptions of the people in the world around us, right? And a lot of that's like, the stuff you read in the paper, you see on the news, like about drugs and drug use and, the horrible stories. And you stigmatize yourself, you shame yourself, right? And you think you're less of a person, you're less worthy. And that's very painful. And then the last one's perceived, where, and we found this in our research, that perceived stigma is always higher. Like what we think others think is much more negative than we ourselves think. And it makes sense, I think, because it's a bit of a defense mechanism, right? I'm just going to assume everybody doesn't like, people with addictions. They're going to judge, they're going to shame, they're going to talk badly. So, and that's, that'll protect me. So those are some of the types of stigma. And this is a classic model. I don't want to get too academic, but a lot of this really starts with stereotyping. And a lot of stereotypes are based on misinformation, not even the reality of it. And a lot of those stereotypes come from labels, right? That person, quote unquote, is a drug addict. They're dangerous. They're a bad person. And so if you go around this circle, labels, stereotypes, status loss, separation is like us and them, right? These people are not like us. They're different. They're suffering something that is immutable, that is unchangeable. And we have to keep our distance, right? And that leads to discrimination. And this idea of like a power differential, especially in certain systems, right? Your healthcare system, you go to see your doctor and you ask for help. There's a power differential there, right? If this person sees me as somebody, quote unquote, like as an addict, somebody who's manipulative, who can't be trusted, am I going to get the care that I deserve? Am I going to get basic health care? Am I going to get medicine if I'm in pain? Right? Frequently the answer is no, right? And that is, that's very dangerous, right? Um, and and really keeps people at a distance. We want people to engage with these systems where they can get help. But the reality is they don't trust, they don't trust those systems. Um, and I mentioned, this idea of intersectionality, different, it's not just drug use, right? It's gender issues, socioeconomic status, your ethnicity, language, right? Somebody who's from another country that may not speak English well. Race, age discrimination is a huge one, right? And older adults are also struggling, massively with these issues. And this creates layer upon layer of potential, stigma. Um, and I think these are just some questions to think about, and some of this you could just take away. I think it's good for us to think about, if I was in this person's shoes, somebody who's struggling, like how is the world going to see me, right? Um, how do you imagine you would be treated? And it's hard, right? Unless you're walking in those shoes. Um, but is it safe to share, right? I know with healthcare professionals, me being one, you ask medical students or residents, would you feel comfortable raising your hand and saying, hey, I'm drinking too much, or, I'm smoking, marijuana regularly because I'm stressed out, or I'm taking, Ambien for sleep every night? The answer is, emphatic no, right? It's not safe. And we have to change the culture. It has to be safe. If it's not safe, that's when people die. Um, and so a lot of what I'm talking about, this kind of these negative perceptions and what you see in the media, and politically what we're seeing, right? We are seeing a bit of kind of stepping back into mandatory minimums and forced treatment, and some of these policies and practices um, that do not have evidence behind them and actually are driving the problem. Drug delivery resulting in death is a charge that prosecutors tend to hold up as something that's a deterrent to this. But what it really does is it prevents people from calling for help. And then frequently you have two people using drugs together and one dies, and the one that survives, ends up in prison. And these kind of things are very dangerous and drive the problem. Um, and so, and you're probably well aware of this, but this was a study done in 2005, but they looked at 14 countries, and they looked at highly stigmatized conditions. They looked at like leprosy, HIV, having a criminal record, drug addiction across every country. Number one, most highly stigmatized condition. Alcohol was number four, and there is a bit of a hierarchy, right? Like if you're drinking too much, you know, yeah, people might get excited, but not so much, right? Marijuana, same kind of thing, right? But if you're injecting heroin, if you're injecting fentanyl, if you're injecting methamphetamine, that's a different level. So very, very highly stigmatized conditions. And, we have this disease model, right? Um, and we center the drug, and I don't want to say that addressing the drug is not important, but there is a problem with this model because addiction, drug use, overdose has very little to do with drugs. In fact, it has almost nothing to do with drugs. The drug is the proximal um, the end point, right? The thing closest, and overdose as well. And nobody wants anyone to die, but it's trauma, physical pain, emotional pain. It's all these, childhood, issues, attachment related issues. I mean, there's a whole host of things that drive, and we don't ask the question enough, why is this individual using a drug? We just say stop and everything gets better. And I'm sure many of you are keenly aware that that is just typically not the case, right? It's an important part of the process, but it's not getting to the root of the problem. And I think a lot of our strategies are aimed at, you know, let's rid society of drugs, stop using drugs, and everything will get better. It is far more complicated than that. And we need to dig deeper if we find, because I know for myself, like it was addressing underlying trauma, and other mental health issues. That was the key to me finding recovery and being able to maintain recovery and living an entirely different life. But it took a lot of work and it took going very deep and it was painful and it takes time. Like we're looking for quick solutions. There is no quick solution, right? This stuff takes a lot of time. It really does. You've probably seen this. This is the American Society of Addiction Medicine definition of addiction, and you can take this away, but this is a complex disease. I always say, you know, as somebody who practiced medicine for quite a while, I think this is one of the most complex diseases there is. You know, it's like physical, psychological, spiritual, like behavioral. There's so many different things going on, and it affects so many parts of the individual um, that it really is quite complicated and takes a lot of time and work. Not for just for the people that are treating and trying to help manage the disease, but for the individual and for the family, right? Frequently, the family just gets left out, and that's like a critical part of addressing these issues. And sometimes, you know, we forget about this part, you know, of the definition, this compulsive behavior despite harmful consequences. And if you think about it, a lot of our strategies are, hey, let's make the consequences harmful. Let's shame individuals, right? Let's make it so shameful, so horrible to go near a drug. And if you do, right, we will punish you excessively. And then when we punish you, if you don't do what we say, we will punish you again, right? And how effective is that, right? We have the data. I mean, just look at overdose deaths in this country, right? I mean, there's many other metrics, and nobody wants anyone to die. We want that number to go to zero, but just measuring overdose and celebrating, oh, overdose deaths went down a few percentage points, that is not a measure of success, right? We have to look at people's lives, right? Are they thriving? Are they connected to their family, to the community? Are they going to work? Are they able to support themselves? There's so many other like important metrics. You know, do they have a sense of hope and a sense of purpose, a sense of community? Um, we don't really look at that, right? Um, and I think it's important, right? We need other metrics as well. Just a couple interesting quotes. You know, I like this one at the top. Every addiction starts with pain and ends with pain. And you know, I think it's important to understand, like, you know, it's not just a disease. It's not just about the drug. It's about these underlying issues. And frequently, it is some type of pain or trauma that is driving this that needs to be addressed. And many of you may have heard of Gabor Mate. I'm originally from Canada. He's a Canadian physician. He used to practice on the Lower East Side of Vancouver, which is an area kind of like Kensington. Some of the most, you know, challenged individuals when it comes to addiction and mental health issues and trauma. I think he spent, I don't know, over a decade down there managing that population. He wrote a great book. He's written a number of books, but one's in the realm of Hungry Ghosts. I would highly recommend it. But this, if I had to design a system that was intended to keep people addicted, I'd design exactly the system we have now, right? And we need to think about that. All right, so my organization, over the past few years, we've launched a couple surveys using a unique technology. The first survey, we captured the attitudes and perceptions of about 30,000 Americans. And the second survey was about 25,000 Americans, including 6,000 healthcare professionals. And I don't want to get into the data too much, but I just wanted to point out a couple things really quickly. So one of the questions we asked was, imagine a person who uses drugs or alcohol problematically. Do most people view this person as a member of their community? And so 71% of us, and actually this first survey, we oversampled Pennsylvania. So we actually surveyed 10,000 Pennsylvanians. So out of that 30,000, there was a large sample from our state. I don't know if everybody's from Pennsylvania, but I imagine many of you are. So 71% of us believe that society at large considers those who use drugs problematically to be outcasts or non-community members. So just think about that for a second. If you're not part of our community, you're an outcast, you're not like us. Um, that's a problem, right? If a large percent of us believe that, because are we really going to support policies and practices, to help this group, right? There will be resistance, um, and that resistance can be quite significant, right? And it's interesting because if you ask people with substance use issues, a lot of them feel very like dehumanized, like less than human. They don't feel like a whole person. Um, and I mean, imagine that, right? You're using a substance, you're struggling, you have mental health issues, and you don't feel connected to the community, and you don't feel like a whole person. You don't feel valued. It's extraordinarily painful, right? And that drives more drug use, right? And more of the behavior that we're like trying to address. Um, this second question, imagine a person who uses drugs or alcohol. To what extent does society see this person as inferior? So almost the same percentage. 69% of us believe that others view people who use drugs as somewhat very or completely inferior. And we asked people what others think to get rid of, there's this thing called social desirability bias, because even though this was anonymous and we're not tracking anybody, a lot of times people are concerned, oh my God, somebody might know that I said this, right? And I have these horrible, horrible ideas and opinions. But these are common views. These are very common views, right? They're not good, but they're common. Um, so this one was we talked about responsibility and blame. So imagine a person who uses drugs or alcohol problematically. Does society view this person as responsible? And this is a really important question because there's been quite a bit or a little bit of research that's looked at, like, if we think somebody's caused their condition or can control their condition, but they're doing it anyway, stigma goes off the charts. Like, we judge them, we shame them, we think they're horrible. If, for instance, like, say somebody's been diagnosed with cancer, right? We know they didn't cause it, they didn't control it. We wrap our arms around them, we love them, we support them, we pour resources in them, we do everything possible. With a substance related issue, right, a large percent of us believe that people cause and can control the condition. And so we're much more judgmental, right? We shame them and we stigmatize them. Unpredictability, this feeds into, fear and dangerousness. Um, a large percent of us believe that others view people who use drugs as somewhat fear or greatly fear, right? And this drives that social distance. We want to keep people at a distance, and we've seen this not just in the general population, but even with physicians. There have been some studies that have shown, like, the majority of physicians think, substance use issues, addiction is a disease, that it's treatable, that people can get better, but they don't want to work with somebody even when they're treated with a substance related issue, right? They don't want to work with them, they don't want to live near them, they don't want their kids to engage, to be close to them, they don't want to marry into their families. And that's a really good marker of stigma, right? Of keeping the distance. And that's like the worst thing, right? Like, one of the most powerful solutions, not in every case, but a large percentage of the time, is closing that gap, like pulling people with these issues, close, people with a substance use issue. Like, frequently we want to keep them at arm's length. And obviously we have to protect ourselves, but one of the most powerful ways to address stigma is to actually stay connected, be there, let people know, like, I'm here for you, I love you, I care about you, I'm never gonna, let you go. Because the reality is they're filled with so much shame, like that self stigma. Society's judging them. They're like pushed to the margins, and that's where people become hopeless. And they want to die. So, um, this idea of fear is really important, and this idea of passing, which is hiding. A very large percentage of us, right, feel that people that use drugs or alcohol problematically will hide their signs of addiction, some of the time, most of the time, or always. And it makes sense, right, when you think about how society sees these issues. I also think that this is actually an interesting measure of societal stigma just generally, right? Because if this number is much lower, people don't feel they need to hide, they can be open and honest, it's probably a good sign that things are improving, like in terms of society, right? I feel comfortable asking for help or saying I'm drinking too much, or I was using a pill to manage my anxiety. So this is a little more of an academic thing, but I think it's an important metric. So these components of social stigma, blame, fatalism, right? You have a fatal disease that cannot be changed. Um, Not true, right? It's just like so many other diseases, including recurrence of use, right? We see similar numbers in diabetes, in asthma, hypertension, and social distance and dangerousness, which I mentioned. There's a lot of stigma around medications. I don't know if you're aware of this, but like a very large percent of us think that if you're taking medications, specifically for like an opioid use disorder, that you are still using drugs, and that is not the case. Medications are a powerful strategy. People get better. The interesting thing is this number is even lower in physicians, right? There's this belief that you're just trading one drug for another. Nothing could be further from the truth, and there's loads of evidence to support that. This is the myth and the fact, right? People who take medications for OUD are just replacing one drug for another, and that's just not true, right? Powerful medicine, when prescribed properly. Even they've done research on diverted, medications for opioid use disorder. And most of diverted medications for opioid use disorder are actually used to treat opioid use disorder because people are having trouble accessing the medication from their healthcare professional. Because even physicians and nurses that have the ability to prescribe these medications, very few want to prescribe, right, these medications. So it's just another angle. And even within the recovery community, right, we have these special meetings called MARA meetings, medication assisted recovery anonymous meetings, because frequently within standard AA and NA meetings, not all of them, but some, there is stigma and judgment and discrimination against people who are taking these medications that are life-saving and life-giving. So it's quite a web, right, to navigate. And just lots of benefits to medication: increased safety, cost effective, reduces risks in all sorts of different populations, in the criminal legal system, right? Very, very important. And medications are expanding slowly. And we could have a whole talk on medications alone, but I just wanted to bring it up. This I found very interesting, and also, disheartening. Almost 3/4 of us believe that others view people who use drugs as having a moderate, low, or no chance of maintaining recovery. And this really is a myth. It's not true. But a large percentage of the population believes that people can't recover and don't recover. In certain groups, like with law enforcement and healthcare professionals, I understand it, right? Because those groups see like a small subset of the population, like the most challenging individuals. Frequently, they're cycling in and out, and they don't think people get better. And that's not true, right? That's not true. This was a study done in 2020 that used data from the National Survey on Drug User Health. And they found that of the 27.5 million people in the United States at the time, that identified as having a substance use issue, right, 3/4 of them today report being in recovery. So the reality is people recover. Most people recover. Like, recovery is the expected outcome of a drug or alcohol related issue. But frequently we don't think it is, right? And I just wanted to put this, like, because like many of us or some of us think the upper left, A to B is the direction, is kind of the expected journey of recovery. And let me just tell you, it's more like the lower right. Mine certainly has been on the lower right. Parts of it have been straight, but there's been a lot of squiggles. And that's the reality of it. And I think a lot of like our expectations and a lot of our systems look at this upper left one, right? Go to A to B to C, right? Go to some meetings, stop using drugs, start talking to your family, everything gets better. Man, it's messy, right? It's super messy. And that's the reality of what this disease is. It's complex and it takes time, and there's a lot of twists and turns. I mean, I'm almost at 9 years now, and it's still like it takes a lot of work, and some days are better than others. Um, and I'm almost a decade into this thing. So, and I'm sure there's people on the call that maybe are, much further along than me, but it's not a straight line. It never was and it never will be. Right. And it's not a straight line for any other disease or condition. Right. Whether you have diabetes, you're struggling with hypertension, mental health issues, you have depression, anxiety, whatever it is, like it's not. But we have this expectation that really is unrealistic. And I think we've touched on all these: the impact of stigma, discrimination, avoidance and secrecy, delayed help seeking, or maybe never seeking help, shame, diminished self-worth, all these different things, right? I mean, this is what we don't want, right? And this is what stigma and discrimination and judgment and shame, this is the outcome, right? And so we have to, move in a different direction. And it put kind of a shopping list of solutions that you can take away here. The reality is each one of these solutions we could have a whole talk on. But some simple things you can use are addressing language. And you've probably heard this, and there's a lot of resources out there. I can share some. I'm sure like Kim and Bob probably have a shopping list of language related resources. But, how we talk about this disease, how we speak to people with these conditions is really, really critical, because the wrong words generate a tremendous amount of shame, self-hatred, and actually drive drug use and addiction. The right words are very healing and connecting, and can be a powerful start to developing trust and putting somebody on the path to recovery. Getting behind medications for opioid use disorder. There's a lot of myths and misinformation about it, but medications are a powerful strategy. Now, I have improved naloxone distribution. I don't imagine anybody's going to distribute naloxone, but carrying naloxone, right? There could be a lot of shame and stigma around that, right? Asking to carry naloxone. But if you think about it, you have a child that's using opioids or maybe is using opioids, that medicine can save their life, right? And I have 2 kids. I would rather my kids be alive, right? Because then you have a chance, right? Harm reduction, in some circles it may be a dirty word, but the reality is treatment is not. Treatment is one, one facet, one solution. Harm reduction is another, right? Addressing, mental health, like there is no silver bullet. We need a multi-pronged approach, and harm reduction is about mitigating risk and keeping people alive, right? And addressing stigma, right? Where people feel safe to have these conversations and feel, connected, that they are loved and supported no matter what, until hopefully, they are ready to move in a different direction. Harm reduction is a powerful strategy. Many people equate harm reduction just with, overdose prevention sites or a safe supply of drugs. There's a huge spectrum, right? Harm reduction is naloxone. Harm reduction is a clean syringe. Harm reduction is just dignifying somebody, treating them like a human being. And some of these simple things, I think everybody can get on board with something there. Addressing these issues in the healthcare systems, sharing stories. I know we're going to have a story in a minute. I think can be really powerful. Shatterproof's done some great work in the state around that, promoting sympathetic narratives. But I think that's the first, stories are great and all, but it's like the first step, right? We need, behavior change. We need to start addressing these issues in a different way. We need to create safe places to have these conversations. And talk about these things. And just this is really for you to take away. This was a study done in 2010, and it's really just an example of changing language. So they use substance abuser or somebody with a substance use disorder, right? That's it, 2 words. And if you look, when we say substance use disorder, people were much more likely to support treatment. What's that? It's about 3 times less likely to support punitive measures. Much more likely to not blame the individual, right? And that's just a small change, right, in language, right? Totally changes the game in terms of how people see and think about these issues. Just some other things, the Kennedy Forum, Patrick Kennedy's organization, is working on parity. We have a long history of not paying for mental health and substance related issues like we have for physical illnesses, right? And there's been all sorts of legislation that's been a real challenge, but supporting that, obviously expanding access to treatment, including access to treatment for special populations, right? Like pregnant moms, our youth, there's not much for youth. Bob and I are on the board of the Bridgeway School, right? There's like 20 spots, one recovery high school in the entire state of Pennsylvania. I don't know about any of you, my daughter's, 15 at a high school, everybody's smoking marijuana, everybody. I mean, there's a cloud over the school. I mean, I hate to say it. And so like we need more programs like that, like Bridgeway, recovery high schools, and some of these other things are more academic, developing metrics to measure and evaluate, integrating people with lived experience, at every system level. Stigma awareness and reduction trainings. There's so much that can be done. Reducing stigma, careful messaging, contact. That's I was talking about, engaging, with people with these issues, keeping them close, using person first language, and continuously evaluating what we're doing, because there's a lot of stuff that's going on. We don't know if it's working. We don't know if it's causing harm, right? So I think that's really important. Just a few things that I'm involved in. Live Well Physicians is a physician support group around these issues. They actually have many other groups for the community around mental health. It's a kind of a CBT, or cognitive behavioral health. It's kind of rooted in that, but there's a lot of great people involved with it. I've been working with the Live Well Physicians group for a few years now. It's great. Our organization is working with the Kennedy Forum on an initiative to create a coalition of healthcare professional trainees, like medical students and residents, who are passionate about addressing all the issues we've talked about tonight. They're doing some amazing work. And we are, some of the survey data that I shared tonight, we are in the process of working with the Pennsylvania Commission on Crime and Delinquency on surveying criminal justice system stakeholders on their attitudes and beliefs around this. And we want to collect data to use that data to go out and improve these systems, right? Get them to care for this population in a much better way. And I do this, a lot of my drive is for my children, right? I want things to be better for them. And that's it. Thank you so much. Hopefully I didn't go too far over time.
Perfect. Great job. Thank you so much, Dr. Fogler. That was fantastic. And I've been loading some things onto our website that you referenced, and I'll share that link in the chat in just a moment. But you mentioned so many great resources, so thank you for that. Now I'm going to turn it over to my friend Kay. Thank you for being here, Kay. Don't forget to unmute. And we're grateful to Kate because she's here to talk about her experience as a family member and the way she views stigma in regard to her loved one's substance use disorder. Thanks, Kate.
Hi, everyone. Can you hear me?
Yes.
Okay, great. My name is Kay, and my son Matthew is 12 years in recovery. So he is now 36. He's married. He has 2 kids. He's doing great. But 12 years ago, he was not. 12 years ago, he was a senior in college down in DC and had been dabbling in different kinds of drugs. I think didn't do drugs in high school. And if he did, we didn't know about it. He could have been, but we didn't really know about it. And long story, by the time he was a senior, he graduated with a degree in finance and an addiction to opiates. And I had a conversation with him. I've been thinking about some of the questions. Yeah, he got into opiates and then he got in trouble with the law. We didn't know about any of this because he wasn't living with us. And then he tried to detox in our basement, and his friends came and told us that he was addicted to opiates. And we staged an intervention and we brought him to rehab. He went to rehab for 13 days. After 13 days, he came out and he said, I got this. We were neophytes. We didn't know what that meant. We thought we could rehab him at home. But I have news for you, for those of you who don't know, 19 months of an addiction to Percocet, 13 days in rehab will not do it. That is not nearly long enough. We learned through joining the support group and doing much study into addiction and into the effect that it has on the brain, that it really takes about 18 months for that brain to heal from the harm of an addiction to it. So, but we didn't know that. We thought he could rehab at home, and that's when the trouble started. He started stealing. He stole from our neighbor. The police were on to him, and one day the police came knocking at my door and told me that they believed he was a person of interest in a burglary like within 100 feet of my house. And these things were so traumatic. They were so traumatic. He was always a good kid. He was the oldest of my 4 kids, and this was very uncharacteristic of him. He talks about his addiction to opiates as being completely hijacking his brain, hijacking reasoning skills or anything. He said he was completely physically addicted and needed the pills to function. Otherwise, he couldn't function, physically addicted to them. When asked why he started in the first place, because I'd like to cut to some of the questions that were posed by ahead of time. I received some questions from some of you folks. First of all, my heart goes out to all of you who are now still struggling with their child or loved one who is in full addiction. My husband and I have become very, very involved. We are the treasurers of the Rosemont Parent Group that meets every Wednesday night at 7:00 at St. Thomas in the church. And every Wednesday night we get more and more people that come in, unfortunately, to our meeting. We like to think that because we experience a lot of the stigma because of addiction, because our child went to jail and his arrest and the dramatic way that happened was televised, not the actual arrest, but because he surrendered to the police department in our area, we secured a lawyer for him, because, I mean, we didn't initially, we didn't want our son to go to jail. We wanted to try to help him get clean and help him, beat this so that he wouldn't have to go to jail. So we got a lawyer, and he relapsed and was really, really caught by the police and pretty much thrown in jail. He did surrender to the police department and admitted what he did, his wrongdoings, and therefore it became public knowledge. It subsequently was on the news. Jim Gardner mentioned his name, and then it was on the internet. And then before long, kind of like what was our little secret at first, because we didn't tell certain family members and most of our friends about it. We had joined the support group really early so we could talk to those folks, but not everybody else. But then once it became knowledge, it was almost like a gift. It was a gift to us that it was broadcast in a way, because as you probably have heard from the rooms of recovery, you're only as sick as your secrets. And we were very, very sick. We were very sick, because we felt like the shame and the stigma of, oh my God, my kid, what has he done? And people wouldn't believe this. He'd never got in trouble before. What is happening? I wanted to move. I wanted to move to Italy. I was like, I need to just get out of here. But none of that was going to help. We really had to, we had to face it. So once he landed in jail, my husband said, we have a decision to make. You're either going to stay in jail for the sentence that they give you, which was it was frightening. It could have been a 2-year sentence, or you're going to go to rehab for 90 days and then you can get clean, and then you will talk to the judge and maybe they'll reduce your sentence. But the lawyer said, no matter what, you're going to have to do some time. So while he was there, he decided to stay. And that was a pivotal moment in his recovery. He talks about it, when he just decided he was going to start doing his time. He was going to detox on the jail cell floor. It was harmful. It was painful. And, I'm sure it was horrifying for him. But once he did, our constant visiting him, our constant support that we gave to him, and encouragement that we gave to him, and got him through that time of incarceration of 18 full months. The last 6 months were in a boot camp type jail, which was very beneficial for him. It got him sort of addicted to exercise and calisthenics, and to this day, he's extremely healthy. In that regard, I guess he's switched his addiction from drugs to exercise. But we asked him, why do you think you got addicted when so many of your friends were trying opiates to party with down in college in DC? I know that's horrifying for us as parents. We're like, why were they doing that? That's so dangerous. But they were. But some of them didn't get addicted. Some of them are dead now, but some of them are in recovery now. And some of them didn't get addicted. And he said he believes it's a combination of biology. It's in the genes. He has a very addictive personality, even to this day. Some of it was environment. His first time experience with the drug gave him euphoria, and it wasn't a bad experience. So it was a good experience with opiates. And his mindset at the time. So his mindset at the time was, this is not, it wasn't being unmanageable. His life was manageable. So his addiction, it was allowed to grow. And when we brought him back into our house, we learned that we can't call the 3 C's, right? We can't cause it. We can't control it. We can't cure addiction, but we learned that we were contributing it. The 4th C is contribute. And as parents, if you give them, I call it 3 hots and a cot, you make them comfortable, you can contribute to them continuing with their addiction. I would like to just quote Mike O'Tay, because I love what he says when he says, as parents, we need to get comfortable with seeing our kids feel uncomfortable. And that's pretty much it in a nutshell. We needed to understand that he was going to have to suffer the consequences of his addiction before he was going to get clean. And for him, the consequence was a legal consequence. He did get clean in jail. He has been clean and sober now for 12 years. He thinks it's the best thing that ever happened to him. He thinks he needed that break. He thinks that no walls of a rehab, he was 24 years old, so he could just walk out of a rehab. He thinks no walls of a rehab could have kept him from using that drug. And so I'm just here to say that, well, all of this really sucked. You know, it was really awful when it was happening, but we are living proof that family can recover from this disease. We were fractured at first. The kids weren't talking to each other. He had siblings that did not visit him in jail, did not write him letters, but then when he got out, they reconnected. Now they're really, really close. And he lives every day with an attitude of gratitude. We, you know, we do too. And I don't want to minimize the importance of having faith in a higher power. He does work a 12-step program, but he doesn't go to meetings. He lives in San Diego right now. He's moving to Virginia. And he may get back into the meetings when he gets down there. I don't know. I don't know how he's going to manage his recovery, but it's not really any of my business. He's a grown man, right? He's 36 years old. So I know that my life changed in many ways for the better. I mean, my son's addiction essentially dismantled me as a mom. And then as I picked the pieces up together with a little bit of faith in my higher power and a lot of help from friends in the support group I'm in, today I can say I'm a happy, healthy mom of an addict in recovery. If anybody has any questions, I'm here to take them.
Thank you so much, Kay. That was great. I really appreciate it. And I'm glad your connection hung in there for you. I know it's very shaky right now, but very crazy weather, at least here in the Philly area. I'm sure a lot of places, but we're all good. We're all here.
Okay.
Great. So thank you both very, very much. So I want to open it back up to questions now. Anybody that has anything they'd like to share or ask? I appreciate you saying that. I think that was very beautifully said, and I couldn't agree with you more. And I know that as family members, we also talk a lot about stigma and the shame that we feel, and the judgment from friends and family. Like, well, in our family, we've had people say this to me, like, well, we were very open, and we have very open conversations in our family, as if we didn't, right? As if that's what caused my son's addiction. And I love some of the language that I've learned. And I agree with you. I think the word enabling has become extremely stigmatizing for us family members. There's an author named Diana Clark who wrote a book, and she likes to say that we family members tend to protect addiction. We're trying to protect our child, and what inadvertently happens sometimes is we're protecting the addiction by trying to keep them safe and housed and fed, and Kay mentioned the three hots and a cot, that kind of thing. Like, that's our natural inclination. Of course, we've been nurturing and protecting our child since they came into our lives. And now is when we're going to change that, so it just feels so counterintuitive. And then people will look at us as if we're You know, I know that Kay mentioned contributing to, and I think that's what she's talking about, is that protecting addiction. You know, that is not our intention, but that is unfortunately what sometimes is happening. But it's completely natural and understandable from the perspective of somebody who wants to protect their child. And how do you distinguish the child from their disease? You know, well, a lot of times the person that we're talking to who's asking us for money, who's begging us to let us stay at the house, it's really the disease that's talking to us. It's not our child, because you're right. They want it to stop. They want the pain to stop, but it's so difficult. It's just so challenging. So I really appreciate, I'm very sorry for your loss of your daughter, but I'm very grateful that you're here and you shared. So thank you. I think somebody else had something to say. Go right ahead. Go ahead.
Yeah, you know, genetics is important, but just because you have a genetic predisposition does not mean if you use a substance, you're going to get addicted. There's so many, I think that's one of the things that makes this such a complex disease. There's so many other factors that go into this. And so, no, it's not like a foregone conclusion. I think obviously it's important to be aware. You know, I never knew my biological dad, and on his deathbed, the family reached out to me and shared he had struggled his whole life. Right. And my first thing was like, man, I wish I knew that. Now, would my behavior have changed? Would I have been more careful? Maybe, maybe not. But I would have liked to have that information. But I think just awareness and understanding, and obviously having a son in recovery, like I'm very open with my children about my recovery. They know, you know, we speak openly about it. I think that's one of the most powerful ways to, you know, in terms of protection and prevention, having those open conversations. So, yeah, that's what I would say.
I would like to add to that we have another speaker who's been with us. Some of you know Dr. Kevin McCauley, another physician who's in recovery, and he was asked that question about, yes, it is a risk factor to have the genetic predisposition, but he also says that recovery is something that is heritable as well. So you mentioned that your son is in recovery. That's a beautiful thing, and that is certainly something that is being modeled for his children. You know, and there's that awareness is a huge benefit, of course, as well, because so many of, as Dr. Fogler just said, it is closeted sometimes and it's not discussed. And so if we have family history of diabetes or hypertension, hopefully we're going to share with our children that, hey, we have to really watch our diet and exercise and things like that. Hopefully we would do the same when we talk about substance use. And Kay, I don't know if you wanted to add, but I also see a hand up.
I just wanted to say that my son, who I just told all of you his story, he has a 3-year-old daughter and a 6-month-old daughter. And I've often wondered how and when he's going to sort of like approach this subject. But I've made a promise to myself that I'm not going to be the one that raises this subject with them, that it's his story to tell, right? He's married to a physician, and the two of them, I'm sure, will talk about addiction with their girls at the right time. They will pick the time, and not me. And they're very open about it. It was funny when I asked my son before I spoke this evening, why do you think you got addicted? People might be asking or wondering what you think. And he said, well, first of all, I mean, a little bit of it is just my biology and the way I'm wired. I have a very addictive personality, as you know. So I think that his, he'll be the one to talk to, his kids about it. And I don't worry. I have a little mantra that I say to myself: if you worry, why pray? If you pray, why worry? So I don't worry anymore. I really don't. I pray, I keep it really close to my heart, my relationship with my higher power. Okay. So I like to enjoy my granddaughters. I don't, I try not to worry about, are they going to pick up? Are they going to get addicted? Am I going to be dealing with that when they're I don't worry about it. I have less control. I can't worry. It's like the Serenity Prayer, right? I can't worry about what I can't control. Um, and I certainly cannot control that. But I am living every day in absolute gratitude that my son is in recovery. And that's all we have is today.
Kim,
Thanks.
can I add one more thing?
Yes.
I mean, if you think about drug use and addiction, it really is a search for a solution, right? Like people, they can't manage their emotions, they whatever, they didn't learn from their family, they have, you know, anxiety, depression, whatever it is. They are searching desperately for a solution to manage their pain. I mean, that's what it is. And when you get into recovery and you start doing things differently and seeing the world differently, and you learn to manage your, you know, you get a whole bunch of tools in your tool belt, and you learn to manage these feelings, which takes time and a lot of effort. Like massive transformation happens, and when your children see that, like you know, your son's in recovery, and they see that, they are going to learn, right? They're going to learn strategies from a person in recovery, and that's really, really powerful. And so, like in some ways, as much as there's a genetic component, and I don't know if Kim said it or Kay said it, somebody said it, like just having that person in recovery is like a powerful force, you know, that can kind of echo into the next generation and onward, you know. And I know, like for myself, like I didn't learn that stuff with my family at all, you know. And recovery has taught me that, you know, and it continues to teach me that. So, you know, I think I would be very hopeful, you know.
Very nice. I don't know if many of you have seen the film. It was back in, I think, 2013 that Greg Williams made called The Anonymous People. And I love that film. And it talks a lot about stigma and how, you know, the anonymity piece is about 12-step meetings. You know, it's for the newcomer, it's for the meeting. It's like, so Bill Wilson, who's the founder of Alcoholics Anonymous, he spoke in front of Congress and said, you know, my name is Bill Wilson and I'm a person in recovery. You know, however he said it back then. You know, this was founded in 1935, but you know, he didn't say, oh, and I go to the meeting on Pine and Fifth and I saw Sean there last week, you know. So it's all about, you know, meeting people where they are, but the point of that film was, because the meetings are anonymous doesn't mean that we have to be quiet about this and silent about it. And so I really appreciated that. And thank you for what you said. It's a great
Exactly.
question. Sean, would you
Yeah.
like to chime in? Go ahead.
Yeah, it's an excellent one. I mean, I think the best way to find out where we should put our money is by talking to people that are struggling with this disease, people in recovery, right? They have the ultimate metric. I think, you know, some of the like federal government agencies are and like it's hard for government because they're not agile. They're frequently responding to data that's years old. You know, SAMHSA does some great work. Is it perfect? There's no agency that's perfect. You know, NIDA, National Institute of Drug Abuse, they've done some great work. There's also some questionable stuff there. So I don't think you can just say it's one. I think it depends on the initiatives that are going on. Shatterproof's done some good work. I mean, I'm trying to do some work, you know, around, and I am doing work around collecting data and quantifying the problem and then using that to not just talk about it, but to drive behavioral change. I think the one system that we have to really address is the criminal legal system, and people don't really want to talk about that or are very hesitant to do that. And I mean, Kay shared, a very powerful story about her son and how the, criminal justice system helped him. And you hear stories like that. I'm not a big proponent of that. I think it does more harm than good generally across the board, but I'm also a huge supporter of many pathways, and that worked for him. It transformed his life, transformed his family life. So we have to celebrate that, right? So I know I'm not directly answering your question. I'm like dancing around because I don't know. And I think like part of the challenge with this, especially with all this opioid settlement money, like coming into the state, $1 billion plus, is that, not just because we're on this call to be a part of the conversation, but even before we started this call, I said to Kim, oh, are you accessing this money? And there's a lot of great organizations doing great work that are having trouble accessing this money, and these funds are going to, strategies that are kind of old hat or that are really just dealing with the surface. And I think like what we need to do is identify, I think one area are the recovery oriented systems of care, because I think like even from my own experience, like you go away to treatment for a while, the real work starts when you get out, right? And people need so much support,
Right.
from 1,000 different things, and we need to be building a robust framework. And like naloxone is important, but all you hear about is naloxone and treatment and naloxone and treatment, and yeah, like that's important, but that's like the tip of the iceberg. And so I don't know if the government agencies are where we should be putting our money, and they have plenty of money on their own. I think, organizations like this, Shatterproof's done some stuff around storytelling. There are some good like law enforcement diversion programs in the state that are smaller, that are not, they're not being done everywhere, that could be expanded. So I think we need to identify things like that. And I think you have to talk to the people that are closest to the problem. There's this criminal justice advocate in New York. His name's Glenn Martin. He has this quote. He says, "People closest to the problem are closest to the solution, but furthest from the power and the resources." So we need to talk to the people, on the ground that are living with this disease, people in recovery, people that have been impacted by the justice system related to substance use and are now like in recovery, trying to move forward with their life, and talk to them. What do you need, right? You don't need to be saddled with a criminal record, right? You need support. You need to be able to get a job, to get housing, like things like that. Right. So, I'd be happy to send you a list of organizations that I like, but it's just one opinion, So the reality is, I think in every one of these, government or non-governmental, there are some, great people doing great work. You can find them, and they're everywhere. But I think we need to be having these conversations and talking to each other, because a lot of times we don't know what each other are doing. And we need to invest like in an organization like this one, that's doing really impactful work. That was a very long-winded. I really wasn't trying to dance around your question.
Yeah. And
it's a great question.
It is a great question. I would add that, talk to your elected officials, because that's another really great way to reduce stigma, is because God knows they hear from the cannabis industry, this industry, the nicotine industry, like they hear from the people that have money behind them, but they don't always hear from their constituents, who's really who they should be hearing from. So I know that we tried a lot, but we're coming from the prevention and treatment world. And so I'm sure they see us as biased. So when they hear from people who are out there living this, in the trenches, dealing with loved ones, crisis and pain, that makes a big difference. That carries a lot of weight. And the more we talk about it with them, the more I think that they have some sensitivity toward these issues as well.
And there's a number that are in recovery, yes, in Pennsylvania that I know that are very passionate about these issues. Yeah, absolutely. I think that's amazing. That's exactly right. Because they don't know. They don't know. I always, I always used to assume they knew and they had researched all this stuff. Yeah, it was like, yeah, yeah, totally. It's important.
Only we could merge drug treatment with the penal system because that's where our loved ones are. People who are
Right.
incarcerated, I don't know, maybe Dr. Fogler knows the percentage of people incarcerated who have a substance use disorder. I know it's very high. It's a very high number.
Yeah, the Bureau of Justice Assistance reports that 65% of people incarcerated have a substance related issue. And if substances were involved at the time of the crime, like somebody without an issue, but maybe they were drinking too much and they did something crazy, it's like 85%. I mean, the jails are filled with people with mental
I
health
know.
and substance use issues.
I know.
It's massive.
It's thin. It's horrible.
And it's so unfortunate because this is not a criminal disease. This is a behavioral,
No,
this is a public health crisis that we have. And
it's a brain disease.
it has unfortunately these, very
Right.
complicated symptoms and side effects. So anyway, we are over time. So I want to respect everyone's time. Thank you. This has been a wonderful conversation. Thank you so much, Dr. Fuller, and thank you to Kay, and thank you all for being here. Stay safe and dry and in your homes. I think it's really nasty out there, at least in this region. So thanks.
Thank you so much.